There are 4 procedural steps to be followed, where step 1 is identifying the area of insertion, step 2 is anesthetizing the insertion area, followed by step 3, which is the insertion of the tube, and step 5 includes removal of the fluid. Step 1. Identify the area of insertion. Identify the insertion site, which usually is on the 4th or 5th intercostal space in the mid-to-anterior axillary line. The insertion site is immediately behind the lateral edge of the pectoralis major muscle. Step 2. Anesthetize the area of insertion. Prepare and clean the skin using povidone iodine or chlorhexidine solution and allow it to dry. Raise the skin while using the 10 ml syringe and 25 gauge needle at the incision area with 1% lidocaine solution with epinephrine. Step 3. Insertion of tube. Make a transverse incision of about 2 to 3 centimeters through the skin and the subcutaneous tissues. Extend the incision by blunt dissection toward the superior border of the rib using a Kelly clamp, and, once reached close and turn, push through the parietal pleura with steady, firm, and even pressure. Insert a finger into the pleural space to explore the anatomy. Hold the end of the chest tube with the clamp and guide it with the finger through the tunnel into the pleural space. Once the tip of the tube reaches pleural space, remove the clamp and advance the chest tube. Confirmation of the location of the chest tube by observing the flow of air or fluid from the tube. Step 4. Removal of fluid. Suture the inserted tube to the skin securely to prevent slippage. Use a simple suture to anchor the tube, or use a horizontal mattress suture to allow the hole to be tied closed while removing the tube. Apply an occlusive petrolatum gauze dressing and connect the tube to a drainage apparatus and securely tape to the dressing and the patient. All connections between the patient and the drainage apparatus must also be tight and securely taped. Let us now understand the post-procedural considerations. Ensure the comfortability of the patient. While a chest tube is in place, the tube and drainage system must be checked daily for adequate functioning. Regulate and maintain the suction pressure for the presence of air leak. Routine daily chest X-rays are not indicated to monitor chest tubes in the intensive care unit unless there is a clinical necessity. If a pneumothorax persists, increasing the suction level may be beneficial, but an additional tube may be required.